to partner with Health in the Community Hub. We want to make sure everyone understands the broad timeline for launching the Community Hub and next steps for interested partners. And we are recording today's webinar. So you should have just gotten a little message about that. And now I'm going to invite Healthier Here's new CEO, John Kim, to give some welcome remarks.
Thanks, Tavish. Hello, everyone. If you feel comfortable to come on camera, I would just love to see my screen filled up with faces, because that is what energizes us. Ah, see, you all look awesome. Thank you so much for being here with us. As Tavish said, many of you know us from MTP 1.0, and we're going to talk about how 2.0 is different. But I want to say thank you for all of the amazing work that was done over the past 5 years, because we learned some really, really important things, and we were able to pass those on. We learned that whole person care, that's what we're after. And coordinating care across silos is really hard. And so this project that is coming up came out of the learnings of the first 5 years. And I can't wait for you to hear about how what we've learned is showing up in the way that we're being asked to not just talk about the problem, but we have a chance to actually be the change that we want to see, to be the change that makes it possible for people in need of many services to go someplace and get navigated to the places where they need to get services from people that they trust, from people who understand them. And that if we can make this part of the system, this is the kind of change that we could be. And then it gives us the power to go and persuade other people about how important this change is and the ways in which they can make changes of their own to enhance what we're doing, to make it stronger, to make it more sustainable. This is an exciting time for us, and we can't wait to share what we know and to find ways for us to help each other be better, because there are populations out there who need us to be better, better than we've ever been, better than we are today. So I'm going to turn it back before I start frothing at the mouth and say, I'm so glad to see you. Thank you so much, and get ready.
Thanks so much, John. And now we are going to turn it over to Michael.
Thank you, Tavish, and thank you, John, for getting us all excited about where we're headed together as we learn more about the Medicaid Transformation Project 2.0. I get the lovely honor of setting some early stages regarding the shared terminology that will help you understand the rest of this conversation. And some of it's new terms for some fairly familiar concepts. So we wanted to make sure that you understand how we're using these terms and recognize that it might be, you might need to hear it more than once in order to intuit and internalize those meanings. So we will be using these throughout the day, and happy to answer questions as they come up for you. But also know that we will be sending out these slides so that you can reflect back on what has been shared today, because there is a lot of information. The first really is health-related social needs. And this is an individual's unmet adverse social needs that contribute to their poor health, as a result of their underlying community's social determinants of health. And we understand social determinants of health as the conditions in which people are born, grow, work, live, and age, as well as the wider set of systems that impact their daily life, including policies, systems, social norms, social policies, and political systems. Health-related social needs are the result of some of these lived experiences: food insecurity, housing instability, unemployment, or lack of reliable transportation as some key examples. We know that these health-related social needs drive health disparities really in different ways across different populations, either by race, ethnicity, culture, geography, and such. But when we are saying health-related social needs, they really are in a service specific to address a social determinant of health. The other term that we're using throughout this presentation is community-based care coordination. And this is a term that really is intended to acknowledge that the supports that individuals and families need across the continuum of care often are very locally based. And our goal in this work for MTP 2.0 is to really center the community in this care coordination, case management work. A community hub, which is what we are aspiring to become and is really a key focus of today's presentation in the MTP 2.0, is a community-centered entity that organizes and supports a network of contracted case management agencies or partners. So the community hub itself is kind of a virtual network or coordinated group of organizations that are collaboratively working together to address needs. The hub itself is not providing those case management or care coordination services. Instead, they are working together to make sure others are working collaboratively together. And then lastly, case management is a term that the Medicaid Transformation Project has been using to define the services that will be available through the hubs. And this can often be used interchangeably with care coordination, system navigation, care management. But we will default to case management throughout the presentation, just so that it aligns with the MTP when you read more about it, and when the protocols and such come out, you'll be able to understand where this fits in the case management service model that is the community hub.
Do you have time? No? You can jump on. I can do that.
Yeah, folks, please make sure you're muted.
Yes,
I'm
thanks,
sorry.
Tavish.
I apologize. That was let me mute.
That's okay. Thank you for attending to that. The focus for today regarding the MTP is about the community hub. There will be some reference to the community-based workforce, because there will be an opportunity to invest in the expansion of and sustainability of a community-based workforce in order to provide the case management services that we will be coordinating through the hub. What we might not be touching on a lot today are the remaining 3 areas of the MTP waiver. There will be a statewide tribal hub that is currently being coordinated and led by the Healthcare Authority, with input from other ACHs and tribal organizations and governments. And we will defer to that at a later time when more information is available. There is an element of the MTP that focuses on re-entry from carceral or jails or prisons, corrections facilities. which will come later in the waiver. So we'll have some time to talk about in the future. And then there is a health equity program component to the MTP waiver. And at this time, those conversations have been pended between the Healthcare Authority and the Centers for Medicaid and Medicare Services, or CMS. And what that means is the conversations related to the health equity components of the MTP waiver have been delayed, and there's not yet a scheduled future conversation. So we are hopeful, and we are still waiting for more information. And so for those of you who have been with HealthierHere since the beginning and throughout the first waiver, we really recognize from our perspective and in anticipation from your perspective that there's a key difference between the MTP 1.0 and the MTP 2.0. And while we want to focus on what the MTP 2.0 is, we also want to make sure that you walk away today understanding more about what it won't be, just to help manage some expectations. So what it is, which will be the remaining part of this conversation as I finish my collective thoughts, is an opportunity to partner with HealthierHere in order to provide those community-based care coordination services through the hub. There will be an opportunity to build capacity and infrastructure for organizations in order to provide community-based care coordination. There will be opportunities to invest in workforce, so perhaps additional positions or FTEs, training or technical assistance to improve the skills and knowledge of your existing workforce, as well as some infrastructure investments if it would help provide opportunities and ways for you to communicate across those sectors that John referenced earlier that can often end up in silos. It will also be an opportunity to partner with this network of hub case management partners. So we'll create ways for case management partners to communicate to each other about how they can best collectively support each other and support the services that they're trying to provide in their communities. And again, the main reason we're doing this is to serve people who have those underlying health-related social needs. So there will be an opportunity to provide direct service as case management services through community-based care coordination. And lastly, it's an opportunity to integrate with the Connected Community Network or the Community Information Exchange. And we'll spend some time later on today talking more about that. What it's not, which is what is different about the first waiver, is this. We had the luxury of really having an unrestricted, flexible funding approach where we could sustain current care coordination and case management programs that are not part of the hub. We were able to resource community, clinical, and tribal innovation projects. We were able to support organizations, physical health and behavioral health organizations, in becoming more integrated in terms of how they assessed and then referred individuals for various conditions. And we were able to initiate some workforce and career pipeline programs that were not related to the hub, but more specifically to some of the workforce shortages that we've seen throughout the MTP 1.0. And then it really was a focus on building capacity for population health management. So emphasized the development of registries, the use of data to drive quality improvement, and the use of data to improve outcomes of the populations that were being served. So our focus really for this new waiver is more about the whole person care as it relates to health-related social needs and the community-based care coordination, less about the integration of physical and behavioral health within physical health and behavioral health entities. And so some of the, just to say it differently in case it helps to hear it different ways, MTP 1.0 was really flexible in our approach, whereas MTP 2.0 is going to be a little bit more prescribed and a little less flexible in what we can fund. The previous waiver had a broader scope. This newer waiver is going to be narrowly focused on community-based care coordination. In the first waiver, ACHs had a lot of autonomy to choose projects and approaches and how we invested those funds. And in this coming waiver, we will be driving the building capacity and investments in the delivery of those health-related social needs services through the hub. We had an opportunity in the first waiver to really provide some flexible funding for our partners to build their infrastructure and capacity, and with the light touches of helping them do that in ways that were supportive of clinical and community linkages. Whereas in the upcoming waiver, we will be very, very specifically supporting capacity building for the hub case management partners so that they can provide services that could be reimbursed, as well as paid for through contracts for health-related service needs providers. And in the first waiver, we were able to have some contracted partners that just had deliverable-based contracts. In this upcoming waiver, we anticipate contracts that are more focused on service delivery. So for us, it's really wanting to help our partners walk through this change with us, and to try to understand that we are also, as more information comes out, understanding how we can best support our partners through this effort and making this transition to the new waiver. And then I'll end with just a couple of focused about, and John referenced this, that the reason we're focusing on community-based care coordination is the healthcare authority listened across the state, across all ACH hubs. There was an identification that we needed to break down some of these silos so that we could collectively provide a more streamlined community-based care coordination strategy. And while we'll focus on Medicaid enrollees, it really is in the service of improving the health of all people. And we really wanting to build on the ACH's ability throughout the first waiver to be a neutral convener, a trusted partner, a steward of funding, and also an entity that can help provide training and TA and quality improvement support in service of advancing whole person care, with now a more focus on addressing those health-related social needs. So we are hoping to help us shift from that physical and behavioral health integration to a model that focuses on the other side of the healthcare continuum with addressing the health-related social needs as that whole person care. We're hopeful that as we do this, the benefit to our communities will that there will be less barriers, less silos, that'll be easier to connect to supports and resources, with improved opportunities to navigate the health and social systems with the hub partners intentionally collaborating together, and that they'll be able to build a network that is culturally responsive, that reflects the communities of the people we're serving, and that will be able to improve coordination across those sectors. We're also hoping to use some of the information we learn about providing these services when we need to advocate for more services that may have needs but may not have availability in the community. And we're also excited that we'll be able to do a fairly robust investment in a workforce that is based in and serving the community. And lastly, I don't want to read all of this slide to you, but just really recognizing that we have been on a journey together through a number of different initiatives, through the Care Connect Hub more recently, for several years regarding the community information exchange, a lot of work related to shared care planning and breaking down some of those barriers about how do we collectively serve an individual so that their particular health needs are and priorities are met. And we're able to kind of take all of this learning and shared experiences to help inform the future community hub as we, again, build that network of case management organizations. So I'll pause there and see if there are any questions that come up before we move on to the specifics of the community hub.
And if you have a question, feel free to unmute, ask your question. You can also raise your hand and Graham will call on you, or you can put your question in the chat.
I'll also say that there will be other opportunities throughout today to ask questions, and there will be other opportunities in the future, but happy to address things that come up. We will use the questions that come up to add to our FAQ if we have not already addressed it.
And we've got 3 hands already. Let's do Lily, then JC, then Hiroshi. So Lily, feel free to unmute and ask your question.
Thank you. I was curious, it had been alluded to in previous conversations that the services that qualified as social determinants of health per Medicaid's definition was perhaps more limited. And so I was wondering, and maybe I'm just getting ahead of the presentation, but what services specifically qualify for this?
Michael, you're on mute right now, if you're responding.
Sorry about that. What I had said was that I wanted to answer that question in 2 different ways. One is the idea of serving the whole person for case management for health-related social needs. We are hopeful that there will be flexibility around meeting the needs of the person that is sitting in front of you. So if they identify housing or food insecurity, that you're able to connect them to resources as they are available. And it does get challenging. So the second part of my answer is there are specific health-related social need benefits for Medicaid enrollees that will be dependent on eligibility criteria. And we are still waiting for the details regarding around those specific Medicaid benefits. But it will be forthcoming, and it will be specific by population and by clinical diagnosis. So an example would be an individual might come to a case management partner with food insecurity, and that lacking a specific diagnosis, they would be able to try to connect that person to grocery delivery or food banks, for example. But if that person came to the case management partner and they were of a certain age and had a clinical diagnosis of diabetes, and they were in need of a specific meal, there could be a health-related social needs benefit that actually provided the delivery of medically tailored meals. So medically tailored meals might be eligible for those who are on Medicaid and who meet specific population criteria, but may not be available to everyone. And so we are still waiting for those definitions of which populations and for which conditions those Medicaid benefits will be available. We are hoping that the hub will be able to still serve all of the underlying health-related social needs services, even for folks who may not be able to get those same benefits as if they don't meet the Medicaid requirements. I realize that's complicated, so hopefully that made sense to you, Lily.
Yeah, and we do have more information on that in the next section. But now let's go JC, Hiroshi, Ivana.
And good afternoon, everyone. I hope you're hanging in there. The first question, and the only question I want to ask at this moment is, the Healthcare Authority reached out to us around November 7th regarding something called Making Care Primary. Is in any way you're aware of what Making Care Primary, this 10.5-year thing they're doing from the Healthcare Authority, is that in some way related, coordinated, collaborated with what's you're doing or the people that are upline from you doing? Anything on that? You ever heard of it? You know what's going on? Making Care Primary.
Yeah, no, thanks, JC, for raising that. Yes, Making Care Primary is an additional initiative not funded by the 1115 Medicaid waiver, but still endorsed by the Centers for Medicaid and Medicare Services. But it is, I guess it's more like in a parallel universe. It is in service of the same outcomes, but the investments by the design are really focusing on primary care providers and their ability to improve outcomes. So it will have opportunities to impact and is related to, but not funded by the waiver. And while we're aware of it as an ACH, we aren't directly supporting that work. We are certainly supporting our partners who are doing that work.
Okay, and as part B of that same question, since you're aware of it, is there going to be, because it seems like the way they reached out to Sisters in Common, they know we're not primary care, of course, but the way it's structured, are they looking, well, not about what they're looking for. Here's the question. If one signs on board with Making Care Primary, does that interfere with eligibility and or working with the community hub? And maybe you don't have the answer, but might be one to ask. In other words, if I'm doing work over there with primary, like primary care, broaden their services to be more comprehensive and holistic, and we partner with them to provide services, health-related social needs services to their patients, so to speak, as part of them broadening themselves under that separate initiative. And we partner with the hub, HealthierHere Hub, and we're serving a different person. Will that be double dip? Same person, double dip? Do you have an answer?
Hey, Michael, this is Hiroshi. I might be able to help answer them, but because I went to a HCA meeting yesterday on this very topic, and I'm applying to the MCP program. So,
yeah.
So to answer your second
Hiroshi.
question, I would say probably not. There wouldn't be any interference. The funding streams are completely different. The eligibility requirements are completely different. And it's really aligning with the program that the state is doing under multi-payer primary care. So the way I would look at it is I think, frankly, it'd be complementary. So if I'm a primary care provider participating in MCP and the multi-payer primary care initiative, my incentive is to provide better whole person care, I would be looking to partner. And the hub could be one way for me to do that for services that maybe as a primary care practice or a health system, I can't provide.
Okay. So it's probably not, but it's worth checking out because we're making decisions. You know what I mean? We're making decisions. as we go forward, wouldn't want to step into one and find out excludes me from the other and vice versa. Would make sense to me, particularly when I think about it. If I'm a primary care physician, I definitely, because it came to us from a Healthier Here partner, United Healthcare. They're one of the partners of Healthier Here, and they've been reaching out aggressively to say, "Hey, sisters, we'd like you to really look at this, and what you guys do is good stuff, and these primary care physicians we have as part of their network could benefit from," and that kind of stuff, but wouldn't want to sign in to that and find out I'm excluded from this versus that. Just want to make sure. So can somebody double down and get me a flat out straight, you're good, no matter who you sign up with. You partner with United Healthcare, you partner with any of United Healthcare's network partners, primary care network partners. It wouldn't exclude you or conflict services that you may do within the hub. I appreciate the I don't think so, but I may have to answer a question to people higher than me to say, is it or isn't it? If you get my meaning. Does that help?
Yeah, no, I appreciate that, JC. And so, yeah, I think we can certainly take that on and try to do some intel gathering and circle back to the group of folks on the call through the FAQ. And we can certainly let you know when that is updated. But I am also on the same page as Hiroshi, just that it would be an opportunity to braid funding and not be double dipping. But I hear you that you want a more confident approach. So I think that's reasonable to ask. Thanks for raising it.
Well,
Okay. Yeah, Hiroshi, then Ivana.
All right, thank you. So Michael, the previous slide where you talked about the different efforts that are leading toward this community hub, really the question is, and I've been concerned about this in the past, is are we creating duplicative type things, or is this the strategy for the healthcare authority to use the waiver dollars to create a community hub, a CIE, or is there going to be multiple efforts from the state around this?
Yeah, I appreciate your question. John, I'm wondering if you can provide some clarity around the CIE and the community hub connections. Not the same.
Sure. To go direct to your question, Hiroshi, we are not crystal ball gazers with respect to what the state's going to do. And certainly in the past, we've seen some things where Department of Health and the Healthcare Authority are pursuing things that kind of look like they are perhaps duplicative. And I will say that, even as we're talking about the Care Connect hubs that Department of Health created a program around, they are in conversation with the Healthcare Authority about how they've created something that actually looks like it could merge, or that it could become obsolete based on what happens at Community Hub, funded by the HCA. So we are seeing conversations at a state level between different departments, and I think it's an effort to prevent exactly what you're concerned about, which is that there's like one hub, two hubs, three hubs, and I think what we need is one hub to rule them all. And maybe this is a substantial way in getting there because of the size of the investment that is coming through this waiver.
Okay, thank you. Appreciate it.
Thanks, Hiroshi. Now, Ivana. Yeah, please go ahead with your question.
Thank you, Tavish. So my question is basically around what are conditions for participation? And my question comes from the outreach side of Evergreen Treatment Services. We were successful at participating from our OTP division, but talking about more focused services that would provide services that are linked to social determinants of health and are targeted directly there are in our outreach side of the organization. However, here's the complexity. Outreach side of the organization is funded through grants, and they're not recipients of any CMS dollars. How do we reconcile this? Would there be any, as I said, conditional participation or opportunity for more focused consulting? You mentioned technical assistance, something like that to determine, because when I think about the full scale of services provided by Evergreen Treatment Services, it provides very holistic approach. And then we're looking at potential expansion of services, linkages to care with primary care, and relationship that we have with Harbury. So I think there's a lot of opportunities, but I also know what the struggles were prior to this when we were trying to divert people from ED. So it's a long-winded question, so I apologize for that.
Yeah, no problem, Ivana. So in a couple sections, we are going to talk about kind of those key capacities, infrastructure needed to partner with the hub. And then in the next section, we are also going to talk about the different ways to partner with the hub. So I just encourage you to kind of wait for those portions of the presentation, and then we'll have time for questions again at the end if there's still lingering questions in your mind. And then we've got another hand. So Jeff, go ahead with your question, and then this will be the last question for right now. Yeah, because we are getting a little tight on time.
Thank you so much. I just want to know what some of these acronyms stand for. We don't all speak this language. ACH, what does CIE stand for? Thanks so much.
Okay, so ACH stands for Accountable Community of Health. So that's the type of organization Healthier Here is. Yeah, there's 9 across the state. And we can provide you, maybe send you an email with more information about that. Since this webinar was for current Healthier Here partners, yeah, we didn't provide that grounding, but we are happy to follow up with you after. And CIE is Community Information Exchange. And Michael, I don't know if you want to say more about that.
Only that it's been an effort that has been driven by community input over the last 4 or so years, and it will be a way to exchange data safely in service of knowing more about an individual that you're serving so that you can best serve them. And there is also additional information in future slides, as well as in the FAQ, about how we are seeing the CIE and the hub work synergistically together. But good reminder that we should always define our acronyms first. Thanks.
Yeah, thank you, Jeff, for the question. And now we are going to move along in our presentation. And we are going to talk a little bit about, what is the Healthier Here Community Hub? So under MTP 2.0, a community hub is defined as a community-centered entity that organizes and supports a network of case management partners who provide case management services and connect people to health-related social needs services. So the hub is doing that navigation as part of case management, and then, making those closed-loop referrals to connect folks to services they need, like nutrition supports, housing, financial assistance, etc. And what's special about the hub and the real opportunity we have here to grow our current Care Connect hub is that a hub really centralizes, administrative and operational functions and infrastructure. So it can streamline things for the whole community, allow our case management partners to really focus on what they do best in delivering services. So some of those functions include, contracting with that network of case management partners, managing payment operations, managing and assigning referrals, so a streamlined process for clients to access any number of CBOs by coming to one central place with that referral, service delivery compliance, setting some standards across the whole network, technology infrastructure. Yeah, Michael was referring to the CIE. We'll talk about that a little bit more later. Also standardization around information security, data collection and reporting, and training TA and QI support. And for Healthier Here, so our community hub, we really see it as, a chance to form and support this network of case management partners. And in our network, in our mind's eye, we know we want community-based organizations, tribal-led, tribal-serving organizations, as well as clinical organizations. We want a good mix of sectors. The case management partners, are going to receive referrals to provide case management services to individuals. But we want to make sure our hub honors and leverages the capacity of existing local organizations to provide culturally responsive services to your communities, our community, through a reflective workforce. We really value, folks who have that lived experience and have walked in people's shoes. We find that they're very effective at providing that case management when they've been there before and can relate to the client. We're also going to foster cross-sector collaboration across the network of agencies. We don't want people kind of doing this work in silos. We want to bring people together, share best practices as it makes sense. The hub is also a centralized place of care coordination for referrals to those community-based services. And this does not mean that it's the only point of referral. Folks can still contact organizations directly, but it's a way to centralize things, to make it easier for folks who may not know who to contact, who speaks a particular language, but they're interested in those services. The hub's also going to connect, coordinate, and collaborate on behalf of people who need support outside of clinical care. So making those HRSN service connections. And the hub will also provide a warm handoff to people to clinical care, like if they come in through a CBO pathway, but need health insurance or need to get connected to primary care. Our community hub, so we see it as very equity centered. Going big with the community hub really gives us an opportunity to kind of make these services more accessible to people who have not had a chance to connect to them before. So that's a big part of our equity vision. And we also want to serve the whole community through case management services. So even though, the funding through the Healthcare Authority is for the Medicaid population, we have a vision of leveraging that funding to have a no wrong door approach. So anyone who needs these services can come to the hub, regardless of their Medicaid status. We know a lot of folks aren't Medicaid eligible, but they still may really benefit from the case management services. We know people cycle on and off of Medicaid, and that no wrong door approach is really consistent with Healthier Here's values. And I also want to mention, so Michael shared about the tribal hub. So Healthier Here wants to make sure, Indigenous community members, if they would rather get their services locally through our hub, they are more than welcome to. That's part of that no wrong door approach. We want to give people choice and options. There's been a lot of research that we've been learning about recently, doing some deep dives into what are the key functions of a community hub. And a lot of this is national work. And we have landed on 5 that aren't just being supported by Healthier Here, but are being supported statewide, because Healthier Here and all the ACH's, Accountable Communities of Health, really want to align and make sure we're not doing 9 different things in 9 different regions of the state. So some of these key functions include community and tribal voice and engagement, sustainability and business operations, that's that standard contracting, payment mechanisms, et cetera, care coordination operations and reporting, those centralized referral structures, network management and capacity building, really investing in our network of case management partners to make sure you have what you need to be successful, and community-based workforce support. Yeah, really investing in the frontline community health workers, care coordinators who are gonna, case managers who are gonna make this all happen, make sure they have pathways for growth. Yeah, we want to explore, living wages, just those career pipeline opportunities, making sure they're supported. So that goes beyond just kind of training them in motivational interviewing and trauma-informed care in the here and now. We really want to help this workforce develop. We also have outlined some key functions of case management partners. So this paints a little bit better picture of what the work will look like if you choose to sign on as a case management partner. Kind of over here on the left, it starts out with the referral, receiving a referral from the hub, and that would be based around cultural language match. So we can provide that culturally competent support. Then your care coordinators, case managers would assess, do a deeper screening to identify health and social needs of the client. When the client first comes to the hub, we will have some initial information about what they're looking for. Like, for example, we may get a referral from one of the FQHCs. They did a prepare assessment of this client and they need nutrition supports and clothing for their kids for the winter. Once we assign that client to their community health worker, they would talk to the client, do a little bit deeper screening to find out, are there any other health-related social needs that they can help with. Connect, so that is the piece where the care coordinator, case manager is connecting that client to available resources in the area to meet their HRSN needs. Support, so this is not a one and done touch. Those case managers will, at regular intervals, follow up with that client, make sure their needs were met, and then complete warm handoffs as indicated. Document, so this is a big piece of the hub. So all the case managers will need to, document their activities in accordance to hub policies and protocols. And those are still being developed, and there will be opportunities for community input and co-design into what that looks like. And then the final piece is networking. So for each case management agency to, participate in the network, come to gatherings, come to convenings, participate in QI, QA activities. And with our current smaller hub for the Care Connect program, this network piece is actually, one of my favorite things. We bring the network together every month. The care coordinators have a chance to build relationships with one another. And actually, in a few weeks, we are going to be getting together in person to volunteer together at the ACRS food bank. It's just really great to, see those relationships being built across agencies. Now I want to shift us to thinking about, who will be serving in the hub. So what I have up here, this is data from January of 2023 that we got from Public Health. For Medicaid enrollees. So these were folks who were enrolled back in January. We know that, Medicaid shifts month by month, but this is kind of a snapshot of what it looked like back in January. You see on the left, this is the breakdown by age. So that largest group are kind of younger adults entering middle age, 25 to 44. On the right is the breakdown by race and ethnicity. So you can see this is a pretty diverse population, especially if you compare it to kind of the general demographics of the county. And I'm not going to tick through all of these, but you'll see Native Hawaiian Pacific Islanders, almost 8% of the Medicaid population. Folks who identify as Hispanic Latinx, almost 20%, 20% from the Black community, 14% Asian, almost 4% Asian American Pacific, American Indian Alaska Native at 3.7%. So it's a very diverse group, which is why we really want a network of case management partners that are reflective of the community. And I will caveat this with, we are going to be serving beyond just the Medicaid population, but we are looking at this demographic breakdown just to give us a baseline of what we're going to want the network to look like. But then, of course, we're going to have conversations with community about what other communities do we need to touch going beyond that. On that same note, we also have data about preferred language for Medicaid members back in January 2023. This is just the top 10. You can see English at about almost 87%. That Spanish is number 2, 10%. We've got Vietnamese, Ukrainian, Somali, Russian, Korean, Chinese. That's inclusive of Mandarin, Cantonese, etc. Arabic, Amharic. We know, the communities you work with, speak more languages than just this top 10. But again, this is just giving us that baseline. In a perfect world, our network will include case managers who speak all of these languages and more. Okay, so now I'm going to talk about the key services that are going to be offered through the hub. So on the left, we've got the case management services. This is really the core of what the hub is going to offer. So again, case management includes that resource navigation, referrals to meet folks' health-related social needs. We really see that as the core of community-based care coordination. These case management services through our hub are going to be available to everyone, regardless of Medicaid eligibility. And how we're going to do that is HealthierHere is going to be getting a per member per month rate through the Healthcare Authority for this work. We are going to leverage that to be able to serve all comers and have that no wrong door approach. Over here on the right are the health-related social needs benefits. So this is one of the pieces that where we are still waiting for more clarity from Healthcare Authority. But what we know right now, these HRSN benefits, there will be a payment mechanism for services that meet a clinically indicated health-related social need. In the new waiver, these benefits are only for Medicaid beneficiaries. And as it's written right now, kind of the latest information we have, hubs will contract with some service providers and reimburse them for these benefits for the fee-for-service Medicaid population. And then the rest of the Medicaid population, that are in managed care, enrolled with MCOs, they will get those services those services paid for through their MCO under in lieu of services. So HealthierHere is the hub. We will be able to, pay for these benefits for the fee-for-service population. And we see these HRSN benefits, they can be provided alongside case management. And again, these population services and protocols are still being finalized by Healthcare Authority. We are hopeful that we'll have more information in January, and we will keep kind of the feedback loop with you all, kind of giving you updates as we learn them. But this is kind of the best information we have right now. And now I'm going to walk us through a visual, because I know a lot of folks are visual learners, may like a graphic more than bullet points, to kind of really show kind of how the hub is going to work. So here on the left, this is that first touch point. A client is referred to the hub, and that can be by a CBO, a healthcare provider, a social service agency, or that client can self-refer online using our online intake form, or they can call us and we will get them entered into the system. Here is the community hub. And at the hub, clients are going to be screened and referred to a hub case management partner, and that is going to be based on that culture and language match. The next step, the hub is going to assign that client to the most appropriate case management partner, and then that case management partner is going to do that deeper assessment of the client's needs, what benefits they may be eligible for, and then they will connect them to the most appropriate HRSN, health-related social needs providers, and then do the follow-up to make sure their needs are met. And here on the right, these are kind of different pathways depending on what benefits and Medicaid status that client has. So up here, a hub HRSN benefit partner. So these would be the contracted HRSN providers with the hub itself. And again, that'll just be for the fee-for-service population. Here in the middle, a hub referral partner. So these would be services that are not covered through Medicaid, but are available, in general in the community. Like an example would be, yeah, they connect this individual to a food bank. And then down here at the bottom, these are the managed care organization, HRSN benefit providers. Yeah, as I said on the prior slide, MCOs, yeah, to the best of our knowledge, will be providing these HRSN benefits for their members. So hopefully at the hub and our case management partners, we will have information about what plan that client is enrolled with and be able to refer them to the most appropriate service that's within their network. So that is a visual of the hub. And I hope that's helpful and doesn't cause more confusion. And then we are almost at a break for questions. So I just want to talk a little bit more about what we still don't know. Some of these caveats we keep bringing up. So first of all, and I know I just mentioned this, but it's really important. So we still don't know which HRSNs will be approved and for which specific populations. HCA has also indicated it's going to be a phased approach, and we don't know yet which ones will go first and which ones will roll out later on. We also don't know the mechanisms by which case managers and the hub are going to be able to verify clinical indication for HRSN benefits. Also, HealthierHere needs more information from HCA before we can really figure out how to resource organizations for the infrastructure needed to participate as a case management partner. But that's information we're hoping to have in January. We also need to figure out what reimbursement is going to look like for those case management partner contracts. And we are already, we want to think outside the box there. And then finally, we still need to know more about how the reentry program is going to be structured and administered. Okay, so let's take a break for questions.
Yeah, hi Tavish, this is Graham. We've got a few questions in the chat, and then JC has his hand raised. So I just wanted to start with some of the ones in the chat. First off, the question is the Community Hub concept an administrative entity, a clinical entity, a combination of both? And if the latter, will this funding help build the capacity to do both?
Yeah, excellent question. So, and yeah, anyone else from HealthierHere can jump in. I see it as an administrative entity. And then once we know more in January about the pool of infrastructure funding, yeah, for ACHs for their community hub work, at that point, we will be able to figure out how to resource organizations to do that capacity building to get ready, yeah, to potentially be a partner.
Okay, great. And the next question from Kimberly was, am I understanding correctly, a partner would be delivering the specific service of case management, not necessarily one or more of the services that folks in case management might be referred to?
That is an excellent question. So depending on what services your agency provides, yeah, you could very well be doing both. And at the end of today's webinar, we will be sharing a survey that's going to serve as an interest form, as well as kind of give us a chance to do some gap analysis of who we're missing. And in that survey, you'll be able to indicate all the different, HRSN services your agency provides.
Great. And for the folks whose questions I'm lifting up, if you have any responses, feel free to come off mute and respond if you'd like. But the next question we have is from Karina. Do you have any idea related to how payment would be structured? I.e., would it be based on a number of clients, resources provided, length of service, etc.?
That is one of the things we still, don't know, but we'll hopefully have some answers in January.
From Lily, we have, so as a clinical partner, our participation would likely be limited to providing referrals to the hub unless we are able to create new roles for case management. Would clinical providers who are doing case management and making referrals fit as a case management partner?
On that one, I would say wait till the next section coming up once we've resolved some of these questions, because we will be covering that there, what the different partnership roles are going to look like.
And we've got a handful more in the chat, and then we'll get to JC and Allison, whose hands are raised. So from Andy, who is asking if case management is provided only short term, that equals a term for non-Medicaid people.
Yeah, so that is something we have not discussed. I can't imagine, but we want this to be equitable. So I can't imagine that we would put a time limit on non-Medicaid versus Medicaid. And it'll be up to the case manager and the client to determine kind of how often they need to follow up and whether they want to work on longer term goals once they meet some of those immediate HRSN needs.
Then from Cynthia, how is the payment structure going to address Medicaid patients who are assigned to King County BHO, requires authorization for billing?
So that again is kind of on our list of things we don't know.
From Kevin, we have, can you distinguish between reimbursement and fee for service, if there is a distinction?
So when I used the term fee for service earlier, that was about how folks are enrolled in Medicaid. Of the almost 500,000 Medicaid beneficiaries in King County, there's about 88,000 of them who are not enrolled with an MCO. They are fee for service. A lot of those are, for example, the dually eligible population, folks on Medicare and Medicaid is that secondary payer. Also, like foster care youth, there's specific populations that fall into fee for service. As far as reimbursement, that is still on the list of things we don't know yet. We need to get it figured out.
Okay, so we'll pass it over to JC and then Allison.
Okay. Once heard John Kim use the term in a presentation, the wicked problem. And I think I'm getting the wicked problem perspective and it's going through my head. I'm hearing terms like this: assign, referral. I'm hearing words like, sounds like, are we a department or are we in fee for services, a private entity? I remember hearing John Kim say he's a lawyer by training and practice. And it occurred to me, I'm wondering, are you guys thinking of this as a in-house counsel for a company, meaning a law firm become in-house counsel agreement? Or are you looking at it like you got a problem as a company and you then seek legal counsel and they charge you their fee for the service they provide? Or is it going to be a combination of both? Because I'm not clear as to, once I do a service, whose money is it after I perform the service? In other words, if this person needs this, they were your client, you referred them to my company, I take them on as my client, or I don't get a choice. I signed up to be a referring entity, like a department inside of an HMO. Because even as a managed care organization, and we are contracted with 5, they make a call or referral. They say they make a call, they may call it a referral, but I'm under no obligation to accept anyone because they look at us as freestanding, independent, self-sufficient agencies. So I contracted with them to serve their population, not in a what they call capitated way, meaning I'm not in a capitation, or am I signing up for a capitation, meaning like some medical providers They are doctors that sign agreements with healthcare insurance companies where they say, I'll serve all of your people in this catchment area for this amount of money. That's a fee. And then, of course, patients call, I got United Healthcare, I got Amerigroup, I got this, and it's one of the insurance they accept under the agreement. I'm trying to figure out from this conversation, which is it? Because some of you who've known me for a while know I got a problem with being a sharecropper. Black sharecroppers didn't do real well in the South, okay? And one of the disadvantages of the sharecropper concept for us Black African Americans is we ended up always with the short end of the stick. And so I avoid sharecropper arrangements. I'm very comfortable. Like I said, we got 5 contracts with all 5 MCOs. That works well, but they don't look at us as a department where they can make a referral, like, you know, like if you're Kaiser Permanente and you walk into Kaiser and, you know, and the doctor you went to see is about your eyes and they sound funny and say, I'm going to make a referral over for you so you can see somebody in the ear, nose, and throat department. Am I that? Signing up for that kind of arrangement? Or am I signing up for, well, it looks to me like you got a problem and we don't have that, but we do have a partner, some people we do business with who agree to, under agreement to accept our patients with ear, nose, and throat issues. So let me call over there and set a referral for you there. And they have a right to decide, and they decide, and then they're going to send us a bill and we're going to pay the bill. I'm not sure what I'm hearing here. Sound like I'm hearing both. And if I'm wrong, somebody put me straight.
Hey, Tavish, JC, thank you so much for the wicked problem, because that's what we're in, man. This is a wicked problem. But we're going to get, I think, to a conversation in further on about the different roles that people will be playing in this network that is the hub. And whether you're a provider of health-related social needs services, that's one way of being a participant in this. And if you are a provider of case management services, that's a different way of participating. And then if you're just referring people in to receive case management services, that's yet another way for there to be participation. And so there's sort of, I think we're going to have to think about different ways of solving the problem depending on which category you fall in as a participant in this. And it's not going to be the same. So I think I would say let's hear for a little more clarity about the different roles, and then I think loop around. Does that sound like an okay way to approach this?
Well, yeah, I'm still listening.
Okay.
I'm still listening, but
no, I hear the issue that you're raising.
I'm trying to figure out, is this really going to be a request for qualifications? You know, like RFQ, you know, you're going to hire a law firm. You want to see if they got the ability to serve your needs, or is this really an RFA, which is a request for applications where people are going to be applying to join this partnership in light of the fact, but I'm listening. I'm still listening. Okay. I'm still listening. All right.
Great. So I think we'll pass it to Allison and then Nathan.
Hi, thank you. I think my question may touch on the previous conversation with the other state programs and entities, but I'm wondering if you have any initial thinking on the connections to the Medicaid long-term care system. And in particular, I'm thinking of those folks in home and community settings who are receiving Medicaid in-home care and other benefits as authorized and managed by a case manager in the community.
Yeah, excellent question, Allison. And from what we know of the health-related social needs benefits that will run through the hubs, the ACHs, the current list, which is not final, a lot of them do relate to, seniors, people with disabilities, in that long-term services and support system. So there will be a lot of connections, but until we have the final information from Healthcare Authority, we can't really start that outreach yet. But that is definitely on our radar. And then Graham, Maria, and Michael are going to be putting answers in the chat because we are running really short on time. And was there another hand that was up? I think I saw Nathan, or did that? He's going to put it in.
I'm gonna pop mine in the chat for sake of time.
Okay, thank you, Nathan. Yeah, I appreciate that. Then we are going to move on to this next section, and I may be skipping around a little bit just to make sure we end on time. So please bear with me. Okay, so now we are going to talk a little bit more about kind of the way we envision like becoming a HealthierHere Community Hub partner and the different ways we see, you all being able to partner with us in this work. So there are 3. So the first option is become a case management partner. So that means you would contract with HealthierHere, you would be receiving those client referrals and providing case management services. And again, we do not have the information on what the reimbursement would look like for this yet, but we will have more information to share hopefully in January. The second option are HRSN benefit providers. So these are those health-related social needs benefits that meet a clinical need that HealthierHere as the hub will receive funding from HCA to pay for community members who qualify for them. And as it's written right now, HealthierHere would do this for the Medicaid fee-for-service population. Again, a lot of seniors, dually eligibles. And we will not know more about those HRSN benefit protocols until January. So at that point, we would be able to provide more information about who we're looking for in that pool to be a HRSN benefit provider. And that would mean, like, let's say you already have a service providing medically tailored meals. When you provided those medically tailored meals to clients who came through the hub and had that clinical necessity, they were approved, HealthierHere would be able to reimburse you for those services through that HCA payment mechanism. And then the final option are referral partners. So this is not a contracted role. This is more of that general ecosystem of community-based organizations, social service providers, clinical providers. And your agencies could refer clients to the hub for services, and then also accept referrals from the hub's case management partners when someone has a particular need around HRSNs. And let's say they don't qualify for the HRSN benefit through Medicaid, but they still have needs around nutrition supports, housing. If your agency already provides those services, we would love for you to be able to take those referrals as you had capacity. So those are the 3 buckets for becoming a community hub partner. And now I'm going to do a little skipping around. So please bear with me. And we are going to send a copy of the slides, the recording after this webinar. So I'm not going to go through everything here. But so HCA has told us, we need the broader hub to launch July 1st of 2024. So that is what we're working towards. And we are estimating that in our network of case management partners, we'd like to have at least 40 FTEs as like that minimum, to get us off the ground July 1st. So that is what we're working towards. I do want to talk a little bit about technology for case management partners, but this is an area where we are going to have further opportunities for engagement, in January and early February. So the hub is going to be supported by HealthierHere's Connect2 Community Network, which is our community information exchange. HealthierHere is going to provide the client management system, or CMS, for case management partners through the Connect2 Community Network. It's a system called Connect2 Coordinator. We think it works very well. We're excited to share it with you probably in a demo, later on in January. And the third bullet here, so I know a lot of you have been involved in the CIE Connect to work, and that's a lot about integration and data exchange. So for case management partners, you will need to adopt Connect to Coordinator as your client management system for the hub work. But in the future, there will be the option to integrate your existing technology system over time. So let's say you use Vision Link, another CCS, another CMS. In the future, we hope to be able to do those integrations so that you wouldn't need to use Connect to Coordinator for the hub work. So you could use your native system for this work as well. And then this about CIE, you will have a copy of that in the slides. I do want to cover this before we take a last break for questions. So what we're going to be looking for in case management partners, our CIE advisory group, the AG, helped develop this list, and then the current hub team was also able to give some input. So we're going to be looking for organizations that serve a priority population. So, marginalized communities, underserved folks, organizations that have experience in a priority HRSN service area, that you have leadership willing to commit the time and resources to the hub and potentially connect to integration. There's a piece around technical readiness to adopt Connect to Coordinator. And we're going to be doing some additional touches around that in January. We're also going to be looking to see if your organization currently provides services where you're collecting, patient or client information and protecting that information in accordance with HIPAA. We will also be looking for organizations that are leaders in King County, kind of hold trust with partners, other social service providers, and the community. Frontline staff are interested, ready to participate. Your mission and strategy align with the goals of the hub and the Connect to work. Of course, that you would have available case management FTE to dedicate to the hub, experience providing case management services, and that you've worked with HealthierHere in the past. And this is not a checklist where if you don't check all of these boxes, you're out. It's just kind of a starting point of, what we'll be looking for in partners. Okay, so now we are going to take one final break for questions.
Tavish, we've got a couple in the chat. Do you want me to lift those up?
Sure.
So Nathan asked how the HealthierHere Community Hub integrate with existing hubs in King County, specifically the AAA Community Living Connections, and how will duplicative services data monitoring be minimized?
So that is something we don't have an answer for right now. But if you already work with existing hubs, please reach out to us, let them know kind of who they are, who they serve. So we can start engaging.
And then the other question was, can community members enter the hub through a case management partner organization to ensure cultural and linguistic appropriateness?
Yes, absolutely. And I do want to mention, I hope I'm not getting ahead of myself. So with this Connect to Coordinator as the client management system, you can kind of batch upload your data if you have existing clients that you'd want to continue to serve. But through the hub and with the hub funding your FTEs. Any other priority questions in the chat?
That's it.
Okay.
I believe.
Okay, and then I'm just going to give it another minute or so to see if anyone raises a hand or comes off mute. And then we'll just move into next steps. Okay, so I'm going to move us along. And again, we will send this full set of slides for you. So the slides we didn't go over, you will still have a chance to review. So for our next steps, we have put together an FAQ, and we are going to add to that with a lot of the questions that have been asked today. So that's going to be a living document. You will have the link to that FAQ when we send out the slides. As questions arise, we'll be updating our Community Hub webpage. You will have that link when we send the slides. You can also email me, anytime, and I'll see if I can help answer your questions. Earlier, I had mentioned we are going to follow up on today's webinar with a survey, and this survey is for everybody. And I know we didn't get to all the information today. There's a lot of outstanding questions. So even if at this point you are unsure of how your organization may partner with the hub, we still highly encourage you to complete the survey, just so we can learn a little bit more about your organizations in this case management area and how you may want to engage in the future. And we will send that link. Bram will probably put it in the chat, and then we'll also include it in that follow-up email. And that survey, it's open as of today, and it's going to remain open through December 11th. And we'll send a follow-up email to all the attendees as we get closer to that closing date, to remind you to get those responses in. And then finally, so another way to engage over the next couple months, we are going to be hosting a hybrid coffee hour, as an informal way to answer questions. And this will be, I'll be at a coffee shop, WC Coffee in White Center, at one of the KCHA communities. So you can come in person, or you can join over Zoom. I'll have the Zoom open while I'm there. And then when you get these slides, you will have the dates. It's on Fridays, 10 to 11. I think the second Friday of the month. So that is another way to engage. And then just want to do a quick Healthier Here temperature check. Do we want to do the exit polls? Yeah, it should do this. Okay. Yeah, so I'm going to run these polls, and these serve as kind of an exit survey, to help us at Healthier Here know if we've met our goals. So you should see the polls on your screen. And this first one just asks, did the webinar help achieve our objectives? Did you learn anything about kind of the 4 categories of information we presented? And then once you answer the first one, you'll be queued to answer the second one. And we'll leave that up for another minute before we move to our final polls. And thank you to everyone who's completing these exit polls. This is kind of a post-survey to help Healthier Here kind of know if we met our goals and what we can do better next time. I know one of our challenges has been that we don't have all the information. We want to be crystal clear about that with everybody, but we also don't want to keep everyone in the dark as we're approaching 2024 and you're starting to think about budgeting and like what's going on with Healthier Here. So it was important to us to bring everyone together, get the information out that we do know, and just be very clear about what we don't know. Okay, and I see the polls slowing down, and we are almost at time. So I'm going to end that one and launch our second poll. Okay, and then this poll will help us know, where some of the remaining gaps are, what you still need information on to be able to make informed decisions going forward. And then also about what are some of the best communication channels to keep you and your organization up to date. And we'll leave this up for just another minute so you get a chance to reply. And thank you. This is very helpful information, for us at Healthier Here. Okay, so some folks are finishing up, And while folks are finishing up, just wanted to see, John, if you wanted to close us out today.
Thanks, Tavish. Folks, from the conversation and the flow, it's clear that there are a lot of questions that are still out there. The details are always important, and it is our pledge to really dive down and get there with you, because we are successful only if we as a community are successful. And if we can't answer questions that are important to how you order your business and how you take care of the community, then we're not doing our job. And so keep them coming, and we're not afraid to receive them. We love it. The more questions that you ask, the deeper we can go and the better that we can be. So thank you so much for hanging in there. Thank you, Tavish, for really doing a wonderful job of guiding us through this. And let this not be the end of a conversation, but the beginning of one. Thank you very much.
Thanks, everyone. You have a great Friday afternoon and weekend, and we'll see you soon.